So picking up where our last speaker left off, the study he just presented on motivated us to do further work on this issue. In fact, I should mention that this is a collaboration with the local clinics, and the Direction 180 clinic was very concerned about the high rates of polysubstance use amongst their clients, and wanting to look at ways like what kinds of interventions they could put on, and that's sort of how this area of work got started, was a collaboration with one of the clinics. So I'm going to be presenting on our CRISM demonstration project, which picks up where the last study left off, and is a collaboration across both Montreal and Halifax OST clinics. And we're looking at the feasibility of doing these personality-targeted interventions for addressing the polysubstance use issue amongst opiate substitution therapy clients. And I'll be presenting today some preliminary results from our very first phase of this study. Okay, so first of all, I'm going to talk about some background around the study. So we're really doing two phases of this initial project that's all intended to inform the development of these interventions, or adaptation of these existing personality-matched interventions for use with this particular population. And so right now I'm going to be presenting that first phase, but I'll kind of walk you through what the different phases are. So in part one of our first phase, which is what I'm going to be talking about today, we're gathering quantitative information about the relationships between personality and different reasons for use of different substances. And in part two, we're doing that qualitatively through interviews with clients, and also through the interviews with the therapists in the clinics, to really look at how we need to adapt these interventions to make them really relevant to the lives of the clients that are in these treatment centers. So the existing personality-targeted interventions have been tested mainly as more a prevention program or early intervention program in the schools, although when we initially developed them, they were initially developed with people with substance use disorders, but community recruited, so some of them weren't probably as severe in terms of their addiction as what we're seeing with opiate substitution therapy clients. And then in phase two, what we eventually hope to do is use all this information to actually adapt the interventions for use in a future randomized control trial. So, as I mentioned, it's a collaboration across two different parts of our node in Montreal and in Halifax. And in each of those two sites, we have two clinics, so a total of 4 clinics. So in Montreal, we have 2 low-threshold clinics, CRAN and CHUM Clinique Externe. And in Halifax, we have the Direction 180 that you just heard about, as well as a higher threshold clinic, which is the Central District, the Nova Scotia Health Authority, the OST clinic there. So I'm not going to go through the personality theory too much because we just heard about that in the last talk, but just to kind of walk you through that the two more disinhibited personality traits of impulsivity and sensation seeking should set people up to use for different kinds of reasons. So impulsive individuals have poor response inhibition and emotional reactivity, so they should be using actually for a lot of different reasons. Sensation seekers, on the other hand, are very sensitive to reward, so they should be looking to substances to give them desired sort of more enhancement effects or stimulating kind of effects. And hopeless individuals on the more inhibited or neurotic trait type, they're sensitive to negative. They have difficulties with negative affect regulation, so they should be drawn to substances to try to manage negative emotions generally, and in particular management of more depressed mood states. Anxiety-sensitive individuals are characterized by hyperarousal and are very sensitive to the dampening effects of substances on their anxious states, their negative affect in general, and also in terms of wanting to dampen withdrawal symptoms that they would find very aversive relative to other people. And that was just a summary of what we just heard from Tib, so I won't review that. So let's go on to the methods for this study. So for this part 1, phase 1, we looked at demographic characteristics of our sample, their substance use, and I'm going to be focusing on their reasons for use in the past 30 days, so while they're actually in the methadone clinic. And we developed a motives for use measure just because there wasn't one already in existence that you can use across a variety of different substances. So I'm going to be showing you that in just a minute, but we have them completed for each substance that they've used in the past 30 days. And then we looked at personality using the same substance use risk profile scale that we talked about previously. So this shows you how we set up this motives measure. So we told people that we wanted to have a better understanding of why they use drugs, and we asked them for each item for a drug that they'd used in the past 30 days to draw a vertical line or an X representing the extent to which they used the drug for that particular reason. So we have items, for example, this is an enhancement item. I've used this drug because it enhances my pleasure, for example, because it's exciting, or to get a high or a buzz. And they say never, right up to always. And then we measure where along the line and use that to record the degree of endorsement of that particular item. So the model that we've used in looking at motives for use comes from something that Lynn Cooper developed in the alcohol area and has since applied to a number of different drugs and addictive behaviors. And she talks about looking at motives as that people use for a lot of different reasons, and that we can kind of look at what are they trying to achieve when they use a drug. And we can divide those desired outcomes into trying to manage internal cues or trying to manage things in their external environment. And then we can also have whether the desired effects are positively reinforcing, adding in something desirable, or taking away something aversive, negative reinforcement. And when you cross those, you end up with 4 different motives: enhancement, social, coping, and conformity. So enhancement being used to get a high or for the pleasurable effects, social for celebratory social reasons. Coping can be also divided into coping with depression and coping with anxiety, but to take away aversive states. Mood states, and then conformity used to kind of fit in with a peer group. We added in 2 additional motives. In the marijuana field, people have talked also about expansion motives, so another type of positive reinforcement motive use in order to be more creative or to enhance experiential awareness. And we also added in withdrawal, just because we were very interested in that coming out of the last study, that seeming like people might be using to manage withdrawal, and predictions that anxiety-sensitive people should be more likely to use to try to manage withdrawal. So we had items around each of those reasons. So let's take a look now. I'm going to mention that these are very preliminary results, this week, like we've just analyzed. So we'll take these with a grain of salt, but this is our first pass with our data. So first of all, telling you who our people are in this sample. We have 135 people at these OST clinics, and all of them have been at the clinic for at least the past 30 days. And we use that window because people are reporting on their past 30-day use. So we really wanted to look at their use while they're on methadone. The majority, 65%, are male. On average, they're about 40 years old, 80% Caucasian, and about half of them employed. On average, the methadone dose was 78 milligrams, and quite good compliance, so 29 days out of 30 on average. So this was a quite compliant group. Just looking at what are some of the substances that they've been using, I'm going to attend over on the far right to the past 30-day use. So you can see lots are using tobacco. Alcohol use rates are fairly high, about a third in the past 30 days. Cannabis, about half. We're seeing quite high rates of prescription tranquilizer use, so 41.5%, and we're seeing about a quarter of them are reporting using prescription opiates, even while on methadone. Now, we're going to go through, but for each motive, looking at the different drugs and how people are rating that particular motive. So here's enhancement motive, so because it enhances pleasure. And as you can see, what we would expect is that stimulant drugs like crack cocaine would be quite high here, but we're also seeing that they're using prescription opiates for this reason, for the high. For expansion motive, so this is the one that came out of the marijuana use area, so you can see that the highest drug endorsed there is for marijuana. In terms of social motives, I mean, the social drugs in our culture being alcohol and marijuana, so we wouldn't be surprised to see those are high, but also that this group is using for social reasons as well their opiates, prescription opiates. Now, two things I want to point out in this figure here, coping with depression and coping with anxiety. Consistent with what we would expect, the most highly endorsed drug for coping with depression is prescription opiates. And the one that's highest for coping with anxiety is prescription tranquilizers. But you also see that it looks like maybe the scale isn't distinguishing between coping with anxiety and coping with depression that well, because we're getting high rates of endorsement of both those motives for both those drugs. So that's going to be something we need to think about as we look at the personality relationships. Then in terms of coping with withdrawal, we see high rates particularly of prescription opiate use as well as prescription tranquilizer use for this reason, as we might expect. Now we're just going to take a preliminary look at some sample personality motives relationships that we've had a chance to look at so far. And we picked 3 drugs that were commonly enough endorsed that we could take a look at this. So we're looking at cannabis, prescription tranquilizers, and prescription opiates in the sample. So, in terms of cannabis, I'm going to look at anxiety sensitivity first. So, positively predicting coping with depression motives. We had expected it to be coping with anxiety, but again, I think this is probably an issue of measurement, and we are seeing like a tendency to use that to manage distress, as well as to use cannabis to manage withdrawal. Hopelessness patterns, not exactly what we had predicted, but they probably make sense that more hopeless people are using less for the positively reinforcing reasons of social and expansion motives. In terms of opiates, again, let's look at anxiety sensitivity first, that they're predicting use to manage distress again. Hopelessness, we were a little surprised here, that it was negatively predicting use to manage anxiety and use to manage withdrawal. The only thing we can really think about what might be happening here is theoretically this group is meant to be more sensitive to opiate drugs, and it's possible that they're getting more out of their methadone and so not having as much withdrawal to deal with, but we're not sure what's going on there. It is a smaller sample because there's only 28 people who were using prescription opiates from our sample, so we may need a larger sample size to get more reliable results there. And then we have prescription tranquilizers. And here we found that sensation seekers were more likely to be using these drugs for enhancement reasons, so to get high from tranquilizers. So this we found quite interesting. And it also predicted coping with anxiety motives, which we were a little surprised by as well. It could be that sensation seekers are trying to search for that optimal level of stimulation. They desire it, but maybe sometimes they over-target it, and then they need to take a tranquilizer to bring them down again. Anxiety-sensitive people were more likely, this was all stuff we had expected, that they used more to fit in with peers, to cope with distress, and to cope with withdrawal. So what are the implications here? First of all, it was interesting that enhancement motives appear to be highly endorsed for prescription opiates across all individuals in opiate substitution therapy. Withdrawal motives appear to be important for prescription opiates and prescription tranquilizers. So it really suggests like that management of withdrawal is very important. So pharmacologically, with the methadone, keeping people on the right dose, but also that they need behavioral techniques to learn to kind of manage their withdrawal symptoms. And then prescription opiates are the drug most used to cope with depression, and prescription tranquilizers to cope with anxiety, but both motives were high for both drugs. So is this a measurement issue, or is this just in fact reality that they're both being used for both of those reasons? Anxiety sensitivity was associated with the negative reinforcement motives for use, coping with withdrawal, coping with distress, and use to fit in. Hopelessness was associated with lesser endorsement of more normative, less risky reasons for use in the case of cannabis. So this might suggest some harm reduction implications that if they're going to be using, warning them about use, less appropriate and more appropriate uses. And again, we're really not sure what was going on with hopelessness being associated with lesser endorsement of coping with anxiety and withdrawal. So that's something we're really going to be attending to when we do these qualitative interviews to get more information on. We know now why they're not using, but why are they using? So we know they're using prescription opiates more often from Tibb's study, so we need more information on why. And the use of tranquilizers for enhancement was quite interesting, and it seems that sensation seekers are the ones that are most likely to do this. And Tibb told me a story about one of the people that he interviewed in the study was somebody he'd just gotten out of jail, and he quite regularly would take really, really high doses of tranquilizers to get really, really high, and then he would do things and get in trouble and not really even remember what he had done. But he was definitely motivated for the high that he would get from very heavy dose tranquilizer use. And I think if you look at what Tibb presented and what I presented, together we see all four of those personality risk factors being associated with risky drug use patterns, personality-specific choices of drugs, as well as reasons for drugs. So it does seem that there's reason to adapt our personality-targeted intervention. So we look forward to the next phases where we look at the feasibility with the clinics of adapting these interventions. I'll open it up to questions.